Dr. Capogna, thanks for being with us again.
You're very welcome.
Dr. Capogna, in the previous interview, we saw how numerous clinical and multi-center studies in the United States, Europe, and South America have confirmed the validity of CompuFlow in finding the epidural space and thus helping anesthesiologists obtain a safe, objective, and reliable epidural labor analgesia. Are there any other fields of application for such an instrument? For example, in thoracic anesthesia? First of all, though, can you explain to us what a thoracic epidural is? What's the difference, if any, with the lumbar epidural, and how is it practiced?
Yes, a thoracic epidural is an injection into the epidural space, which is the area around the spinal cord. It can be a single shot injection, and in this case, it can be used to treat pain in the upper to the middle part of the back, or it can be used during surgery for thoracic and upper abdominal areas as an anesthetic technique. The anatomy of the thoracic epidural space is different from that of the lumbar one. The thoracic spine consists of 12 vertebrae. The lumbar spine has 5 vertebrae. The two tracts of vertebral column are different in shape and curvature. Their spinal level roots differ in size, and after the injection of the anesthetic solution spreads differently. Technically speaking, in the low to mid-thoracic area, the vertebral spinous processes are sharply angled and have tips that point caudally, making midline insertion of the epidural needle more difficult. However, without going into medical details, it is clear that these anatomical differences require slightly different techniques, even if for the public it is always a matter of placing a small tube in the back. However, it can be said that the thoracic epidural requires different and appropriate skills anyway.
Dr. Capogna, in clinical practice, what is the thoracic epidural used for?
Clinical indications have expanded significantly over the past several years. The thoracic epidural block is often used to supplement general anesthesia for surgical procedures, especially in patients of all ages with moderate to severe diseases, but can also provide pain relief during surgery and after surgery, and can be used as the primary full anesthetic for many upper abdominal surgeries. In addition, epidural techniques are also used with other procedures, such as, for example, extracorporeal shockwave lithotripsy, or for diagnostic procedures, in acute pain therapy, and also in management of chronic pain. And in this latter case, it's often used like a single shot injection.
Dr. Capogna, can the CompuFlow also be used for thoracic epidurals? What can the advantages of this new technology in this clinical setting be?
Sure. As for the lumbar approach, also thoracic epidural blocks may be affected by difficulties associated with needle insertion and uncertain and imprecise placement of the catheters. For this reason, I believe CompuFlow may represent a great help in properly identifying the thoracic epidural space. The thoracic technique carries a higher risk of meningeal tear, in part because the epidural needle proximity to the dura. In a simulated settings, the CompuFlow instrument was able to reduce this risk, reducing significantly the advancement of the epidural needle tip into the epidural space when compared to the not-assisted technique. As far as I know, there are some centers, also in the United States, that are starting studies and evaluation on this new and promising use of the CompuFlow instrument. And I'm sure that in a short time, it will be also appreciated by my fellow anesthesiologists who routinely use the thoracic epidural blocks, opening up new opportunities in the market also.
Let's take a step back now and talk again about the lumbar labor epidural. This seems to be the most studied field of application of CompuFlow thus far. Do you think this new technology will become the standard of care for labor analgesia, or is it still confined to the experimental stage?
Frankly speaking, the success and safety of the CompuFlow in accurately identifying the epidural space in the obstetric field has been extensively demonstrated. The possible cost savings by reducing complications if used routinely have also been reported. Therefore, this instrument is the ideal candidate to become the standard of care in the labor and delivery settings. I believe that speaking about epidural analgesia, we are leaving the stage of the research and testing, and we are rapidly reaching the time when the CompuFlow will be considered as a required standard in any maternity unit.
Dr. Capogna, thank you for being with us today.
You are very welcome.